We are asking everyone to please mute for the webinar today. So if you could do that, that would be greatly appreciated. And we were expecting 165 people, and we're only admitting the first 100. And that went out on our announcement that we were only going to have room for 100 today. So hopefully we'll get close to that mark today. I see the chat box is active and roaring. I'm glad to see that. So welcome everybody who is commenting in the chat box. Love to see that action going on. All right, so let's get started. This is NIAPRIS Advancing the Use of Advanced Directives in New York. My name is Rob Statham. I'm a trainer and technical assistance facilitator with NIAPRIS in the central western part of the state. I'm joined by my co-trainers today. I'm joined by Larry Hockwald, who is part of the Manhattan, Long Island region, and David Ferenz, who is part of our Hudson River Valley region. So welcome to them. We also have OMH with us today. Kristen McLaughlin is with us. I hope I said your last name right, Kristen. And they're going to be good. They're going to be joining us at the end to talk a little bit about what they're doing with the advanced directives in New York. So welcome everybody. Just a few housekeeping items today. We're asking people to remain muted during the presentation. If you have a question, please throw it in the chat box. If you have comments, it's always good to have conversations that are going on in the chat box too. We will be monitoring the chat box today as well. So we'll get to your questions. And we will have a time at the end of the presentation for questions as well. So we'll leave about 10 minutes at the end to answer any questions that you may have regarding this topic. And it's real interesting that this topic seems to be a hot topic, and I'm so glad to really see and hear that, because it is such an important tool that we can use for ourselves and for the people that we support. All right. If you're not familiar with what is NIAPRIS, we have been around 40 years. This is our 40th year in business. We are a change agent dedicated to improving services, public policy, social conditions for people with mental health, substance use, and trauma-related challenges. We promote the 3 R's: rights, recovery, and rehabilitation. We believe in full community inclusion and people being able to achieve maximum potential in their life. And we do it through advocating, educating, demonstrating, and absolutely celebrating the work that we do. If you're interested in more on what NIAPRIS is and does, our website is right in the corner, and we're actually redesigning it. So it may look different to you in the next couple of weeks. All right. So what we're talking about today, we did put together some real quick learning objectives for everybody. And that is really to explore psychiatric advanced directives and how they support self-determination for people who receive mental health services. Self-determination, critical part. You'll be able to promote the use of psychiatric advanced directives through practical knowledge that we'll be imparting today about the nature and typical use of advanced directives as well, and support a working knowledge of the New York State model of advanced directives. So we're talking about New York State today. It is different across the fruited plains here of the United States. So we're really talking specifically about New York today. All righty. All right, so I love starting off with this quote because it really talks about how valuable advanced or psychiatric advanced directives are. So it says, this time with a PAD or psychiatric advanced directive, I did not receive any treatments that I did not want. They were very respectful, like their caregivers there. I felt like the hospital took better care of me because I had that psychiatric advanced directive. And in fact, this person is saying it is the best care that I've ever received. And I just want to make mention that really a psychiatric advanced directive, or any advanced directive for that matter, is really a gift. It's a gift to the person that it's for, but it's also a gift to the person that is carrying out your wishes. Because I can tell you from being in past experiences with my mother, it wasn't a psychiatric advance directive, but it was an advance directive. The family having the knowledge of what she wanted, particularly at the end of life, was, like I said, it was a gift, because it would have been such a burden for us to kind of figure out what did this person want, what was best for this person. And thankfully, my mother was able to say ahead of time, through the use of a proxy, which we'll talk about later today. But it was really letting her wishes known to family, so we could advocate for her when she was no longer advocate or being able to advocate for herself. Now, I want to talk a little bit about some research here. This is some research from Duke University, or Duke Medical School, that showed that people who completed psychiatric advance directives had fewer coercive experiences in terms of being transported by the police, being handcuffed, being civilly committed, or being restrained or put in seclusion of any way. Really important stuff here. But here's one thing I want to make very, very clear. And this was born out of the research of the Duke study, that people who were just given a form to fill out and a phone number to contact regarding a psychiatric directive only completed it 3% of the time. Not very much. So we're talking about a completion here. Also, when they found that a caregiver or a professional of some sort, or support like we offer, spent 2 hours with this person, interviewing, getting to know this person, the completion rate rose to 60%. Now, and that's a 20% or 20 times increase. That's really important, because it's one thing, to start it, but it doesn't mean anything if it really hasn't been started yet. You want to be able to complete it as well. There's many other benefits here. It just helps somebody with a mental illness preserve their autonomy in ensuring that they have the right care at the right time, like any of us would want in terms of our care. And again, individuals who have this psychiatric advance directive are more likely to work collaboratively with their physician, clinicians of all stripes, just working together, and better able to let people know what their personal wishes are in terms of the type of care that they would like to receive. So what is a psychiatric advance directive? Well, we're gonna answer that in today's presentation. And according to the New York State Attorney General, they talk about and acknowledge 3 different types of advance directives. They talk about a DNR, which we'll talk briefly about, a healthcare proxy, and a living will. These are 3 parts. Now, when we're talking about the psychiatric advance directive, there's would be 2. There would be the psychiatric advance directive and the proxy in and of itself. But here's one thing that I really want people to be clear about when it comes to psychiatric advance directives, or your instructions, so to speak. When it's written down, the instructions become legal. The agent is more likely to be acknowledged, and people around them know about it. So very, very critical that it's written down. I mean, it is accepted if it's not, but we want to make sure that it has been written down. One other thing that I'd like to make clear about advance directives is people use these terms, proxy, a living will, and they mean different things to different people. So you really want to make sure that how you're talking apples to apples and not apples to oranges, because people can get confused by that. Again, a psychiatric advance directive allows people to declare their preferences and instructions for future mental health treatment. Now, New York State has specific laws regarding a healthcare proxy, but for advance directives, they're also called living wills, by the way, the courts use case law rather than statute law. 25 states have passed specific PAD statutes, and JACO, if you're not familiar with JACO, that's the accrediting body for hospitals and psychiatric institutions, require these to be done. Okay. Now, just for instance, you may want to include some end-of-life instructions as well. I know people don't like to normally think about that, especially when you're going to an inpatient, but you just want to make sure that everything is covered. Anything can happen. You just want to make sure that everything is covered as well. This is a great resource. It's the National Center on Psychiatric Advanced Directives. Great materials in there, useful materials. However, I do want to just notice some limitations here. It's generic information. It's not like New York State information. It's very generic, so we want to keep that in mind because laws are different from state to state. So we know in the last several decades, there's been rising interest in this, and it really started with the research, the findings on recovery that people could and can recover from a mental health challenge. Before that, it just wasn't, we didn't think like that. So obviously, if we're finding that people can recover, this goes right in line with psychiatric advanced directives. The whole concept of the recovery movement, the rehabilitation and rights movement fell right in line. And of course, peers started that movement. And so it's falling right in line with psychiatric advanced directives. The Patient Self-Determination Act kind of took this even further. And then the Public Health Law, Article 29, the Healthcare Proxy Law, really made it even better. But here is the bottom line on this. People wanted a voice. People wanted a voice in terms of their care when they could not give that voice, so to speak. So now we're giving voice to individuals. A couple terms I want to throw out so individuals can understand what we're talking about here. Informed consent is a big one. And this is basically, I'm talking about the requirement of informed consent refers to the treatment provider's responsibility to inform the patient about the nature of the proposed treatment, the benefits, the risks, alternatives, or to the proposed treatment that they're looking at, and to obtain the patient's voluntary decision based on understanding of that information and to accept or refuse treatment. Now, this information that we're giving people, we want to make sure that people understand it, that it's clear. I mean, I'll just use an example, personal example, and probably everybody on this webinar can kind of relate to this experience. When you go to the emergency room and they give you the instructions when you're leaving, and sometimes, they give those instructions to me, and I'm trying to read them. I really don't have my head together at that point, but then I go home and I read them and it doesn't make any sense to me. It's all, medical jargon I don't understand, so I can't even follow it. We want to make sure that people are given information that they can understand and really follow through on at that. Then we're talking about the capacity to make treatment decisions. And basically, this is the ability to understand and appreciate the nature and the consequences of healthcare decisions, including weighing the benefits and the risks or the pros and cons of that, and alternatives to any proposed health care, and to reach this idea of informed consent. Now, I want to make mention of one more thing regarding that. A person is competent if he or she can weigh the pros and cons or of the different treatment options and reach a reasoned decision. Does not necessarily consent to treatment being offered. They have to go to be able to reasonably make that decision regarding that. Again, more information on what are psychiatric advanced directives, legal documents that ensure your wishes are followed if you cannot make a decision for yourself. Very simple there. We'll talk a little bit about the New York State Healthcare Proxy. And basically what it is, it lets you name a healthcare agent who will make a decision if you cannot make that for yourself. It takes effect only after 2 doctors decide you are not able to make that decision on your own. Is there a standard form? Yes, we'll talk about that in the resources, and we'll actually show you the form. You can give Copies to your healthcare agent, a close family member, doctors, or others involved in your treatment. One thing I want to make clear about the proxy here is it has to be, you want to make it clear and convincing evidence of your wishes. You want to make it really specific, or as specific as you need to, so individuals know what to do and what you want, what you don't want. In addition, under what circumstances do you not want it and you do want it. So you want to be very specific. And basically this means that if they don't know, if you're not clear, then the agent's not going to be clear, or the person that's kind of representing you is not going to be clear. So you really want to make sure that you are being very clear in terms of what you would like, what you would not like, and under what circumstances for both of those issues. A living will, or advanced directive instructions. What it does, it allows you to say what care you want and don't want, including information in terms of the end of life as well. It takes effect when you cannot make a decision on your own and for the end of life, when your doctor confirms that you have an incurable condition. Is there a standard state form? There is not for that. However, you can also write special instructions into your healthcare proxy form, and a lot of them do. A DNR. So what is it? What it does? It tells healthcare providers and emergency workers not to revive you if you stop breathing or your heart stops bleeding. When does it take effect? When you're signed, when signed by your doctor. The standard New York State form, yes, there is. Some hospitals have their own form, so I want to make that clear. Anyone not in a hospital can use what they consider a non-hospital order not to resuscitate. And so we'll have more information on that in the resource section. And obviously you want to keep forms, any of these forms that we're talking about, where people can see them, because if they can't see these forms, they can't be followed. If you're too sick to agree to a DNR, your healthcare agent or closest family member can agree. And you can also write the DNR instructions into the healthcare proxy or the living will. And medical orders for life-sustaining treatment, sometimes referred to as MOST. Again, lots of information on this slide, but it's honoring patient preferences, and it's just critical in providing what we call high quality end-of-life care. For those of you who have loved ones, you've probably seen these or had use of these. It just helps physicians and other healthcare providers discuss and convey the patient's wishes regarding CPR or any other life-sustaining treatment. And the Department of Health has an approved physician and nurse practitioner form, DOH 5003 there. It's just a way of documenting a patient's treatment preferences concerning life-sustaining treatment. And this is something that we had to do with my mom. We were very specific. The form was very specific. And we wanted to make sure that, all bases were covered, because we wanted the best for her. As of June of 2010, the Health Department updated the MOST form in June of 2010 to make sure it was more user-friendly and aligned with forms of the Family Healthcare Decisions Act and other provisions. All right. So I am going to turn it over to my co-host, Larry Hockwald. Sorry, Larry.
That's okay, Rob. Thank you very much. So I am Larry. I am the NIAPRIS Training and Technical Assistance Facilitator for New York City and Long Island. So, and I'll take it. So a healthcare proxy, a living will, and advanced directive care instructions, all of these things are all together can make a comprehensive traditional advanced directives for adults, for people 18 years of over. So as Rob mentioned, there is a legal form for a healthcare proxy that is making somebody your agent. I don't know if it was clear. That's where you decide, as Rob had mentioned, somebody who's going to make decisions for you when you are not able to make those decisions. So a lot of people I work with, I do a lot of training in the city, they tell me that the people they work with don't have healthcare agents, don't have people that they can say they'll make decisions for me. And later on, we'll talk about the legality of when you have them, when you don't. David is going to cover that. But that's an excellent, a lot of places I'm working with right now, they're trying to create new ways to help people sort of meet up to be each other's healthcare proxies, healthcare agents. So, so what people are doing is they're instead of, we do a lot of work with agencies about creating, expanding on natural supports for people. And what some people are doing is, rather than normally we have people seek out a shared interest, but now people are seeking out a shared purpose. Agencies are running groups and things for people who want to get to know each other, see who has like-minded and could be healthcare proxies for each other. Because as we'll see, the best way to get your needs met is not only to spell them out, but also to have somebody who can interpret them, who knows your likes, your desires. So it's kind of important that you do as much as you can. We want to make things specific so people know what treatment you want. You don't want to make them so specific, like when I'm at this hospital with this doctor, and then you find out that, or then you're not at that facility, or you're not with that doctor, or you haven't updated it, so some things are out of date. So we want to give people the best chance of getting their instructions followed and their needs met. And the best way to do that is, again, have someone who can make those interpretations, so it's not left up to an organization, a facility to say, well, we can't tell what this person wants from what they wrote. And as well as to spell things out so that your healthcare agent, as Rob said, can be comfortable making those decisions between what you put in writing, what you said to them verbally. You want people to, the people you work with, you want them to understand that to get their needs met, people have to understand what they want. Their agent has to understand, and or if you don't have an agent, your paperwork needs to have certain flexibility. It's important to know that these instructions may not be followed in an emergency, and often they won't be able to be followed in an emergency, which is, again, why we have to leave some flexibility. You may always go, if unfortunately the person you work with goes to the same inpatient unit, if they've been there before, they may assume they're going there again, but again, that may not happen. That may be full, the ambulance may be busy, they may end up somewhere else. So we want to build into these instructions flexibility along those lines. So next, please. So when you have a healthcare proxy, when you define an agent who's going to make those decisions for you, they're supposed to make those in accordance with your wishes, including your moral and religious beliefs. They're supposed to make those decisions if they're standing in your shoes, and the person's shoes that made and always in your best interest. But again, those kinds of things are up to interpretation, so it's very helpful when you've had those discussions, when you have been able to appoint an agent, and when you can give enough written commentary in your advanced directives that people understand what that looks like to you, the individual making the advanced directive. So it's important to choose an agent who knows them well and is trusted. And it's also important that they know that they are your agent. Currently, New York state law doesn't require the agent to sign. The principal signs and the witnesses sign. Some forms have added the agent's signature, not because it's required by law, but because it forces us to remember, hey, did I mention you're my agent? We don't want people appointing people who haven't agreed and don't know that they are the agent. And mental health care providers as agents is a potential conflict of interest. And we have to be very careful, not only who we choose, but we know the people we're working with don't always have a lot of choices. They may come to you. You need to understand the conflicts that can arise, as well as there are legal requirements. You, for instance, a psychiatrist, and that'll be covered later, couldn't provide care and be the agent. So if you choose your healthcare provider, now you may limit, now it may change how your care is going to be delivered. Next one, please. So what goes, and we're not going to go line by line in the paperwork, as much as I know you want to hear it line by line, as much as you're riveted on the end of your seat. We're not going to do that, but in the healthcare proxy, which is a legal form as opposed to the advanced directives, which there are a lot of examples out there. They are, they have the name of you, the person who's making the healthcare proxy, the name of the person you're designating, and they have the healthcare proxy indicates that the principal intends to have the agent have all this authority. And you can see we're talking specifically about psychiatric advanced directives. I know Rob mentioned such as end of life stuff. The reason that's there is, unfortunately, and you may have had this in your own personal experience, I know I have, people don't always go in the hospital for one thing and then just get out. I've known people who went in for the hospital for relatively routine, significant, but routine care, and met the end of their life while they were in the hospital. So should the need arise, even though it's not directly a psychiatric piece, people should have certain things documented and as part of the package so that people know that if these situations arise, what exactly they want to have done. And the proxy has to be signed and dated in the presence of 2 adult witnesses. So again, no agent signature, but it's recommended that you have one, or at least make sure your agent knows you appointed them. Next, please. So there's a public health law, as Rob mentioned earlier. The healthcare proxy is a law. The advanced directives are supported by case precedent and case law. It allows an adult to appoint another adult to act on their behalf. Not more than one agent can be appointed at one time. You can't have an alternate, but the alternate can only serve if the primary is unwilling or unable. So if things have changed, you want to update your proxy, because the primary agent will be the go-to unless they refuse or medically, or you put in a thing that if they're traveling out of the country, something that stops them from being the primary. Next, please. So the attending, so every person can appoint that alternate. And the attending physician determines that if the agent isn't available, and you can put in specifics like I don't want them if they're out of the state or something, and then the attending physician will look at what the specifics are and say if they can't be the agent, they can go to the alternate. A court can disqualify an agent from serving if somebody says, hey, I don't think he's doing what's in the best interest or something. They can look at that, and if they agree, they can disqualify them. And as I said, the person making the healthcare proxy can specify, for instance, if they're no longer in the state or they're traveling out of the country. If the person appointed as the original agent becomes available after they go to the alternate's authority ends and the original agent's authority will now begin. The attending physician records this change and the reason for the change in the medical record. Next, please. An operator, administrator, employee for a general hospital, nursing, or mental hygiene facility, or hospice may not serve as agent for any person who's a patient at the facility. We already talked about the conflicts that can arise. You can be an agent, you can be a caregiver. They don't want you to be both. So unless the patient is related to the person they wish to appoint, and then the patient created the proxy before being admitted to that facility. So now they can be at the facility, but as we'll see, while physicians are the exception to this rule, a patient can appoint his or her physician as an agent, but the physician cannot serve as both the agent and the attending physician of a patient after their decision making authority begins. So any physician who has been appointed cannot determine the patient's capacity to make healthcare decisions. So if you have two doctors who are saying you can't make that decision. One of them is your agent. They're no longer able to make those decisions. So again, we want to try and avoid the conflict. The reason these come up is because a lot of the people we work with, they don't have a lot of potential agents. That's why I told you some groups are working on various ways to try and build the natural supports that people can choose from. Choose from. Next, please. So what are the critical issues of a healthcare proxy? It doesn't expire unless you put a date on it to expire. Why would you put a date on it to expire? Because you want to remember to go and review your healthcare proxy. Some people make it, put it in a drawer, they don't see it again. We don't want that to happen. Some people force themselves to review it by putting on an expiration. It can be revoked. It's revoked if the person who wrote it declares it revoked, usually when they put a later version into play. Or if you get separated and you're divorced, or is legally separated or divorced, and your spouse is the agent, your agent, it's automatically revoked. For some reason, New York State thinks your ex may not have your best interest at heart. I know you're thinking, what are they talking about? So in fact, you can make your ex your healthcare agent if you feel you know better than the state of New York. You can do it, but you must create that new one after the legal date of either legal separation or divorce decree, so that it is clear in the documented record that you appointed your ex after they became your ex, just so that everybody knows you made that decision and you wanted it that way. And finally, there's the right to refuse or object. I have a right to refuse or object to something I wrote in my advance directive. In New York State, even if I lack capacity to make healthcare decisions, I can refuse or object to something. So some people say, then why are we doing all this if you can refuse or object? But again, it doesn't mean somebody will. And if they have appointed an agent, that agent can discuss it with them. But they want to have this right. This is also a safety valve. You know, sometimes people haven't updated their record. They became allergic to something, or they don't want to do something, and they remember that, but it's not documented in that particular record. So there is that right. So it's a sort of a stopgap safety measure. But again, it could become problematic, but that's for the healthcare agent to discuss with the individual. If they don't have a healthcare agent, then using their documentation, their advanced directive package, it's something that the facility can take up with them and try to work something out that and understand where everybody's position is. Thank you. Next, please. So the principal states specifically what he or she wishes for healthcare treatment and what he does not want to receive. This is the chance for people to let people know the day in, day out kinds of care, the medicines that haven't worked in the past, so that if you get put somewhere and the person you're working with gets put somewhere and they don't have a direct connection to past treatment, they don't, although with the electronic medical record, hopefully they do. But here's where you can make the specifics. Let people know what's not helpful. Let people know what particularly works for you. People have taken this section from their wellness recovery action plans, their RAP plans, and have incorporated their wellness tools into this. Courts in New York have honored these directions when a person's wishes are established by clear and convincing evidence, meaning the less, you don't always have to, if your agent is saying, I understand Larry wants this, you don't necessarily have to be clear and convincing your agent made the decision. If you just have a document, it's good that it's not up for debate with the healthcare provider. If they can understand what you are looking to do, they have less of ability to challenge that. The more general, and you want to be general enough, as we'll mention in a second, but if you're too general or you're not flexible and they can't meet what you're asking, then there's going to be problems trying to follow along with the directions that somebody went to the trouble to make. They told me I should make my advanced directives, but now they're not meeting the way that a hospital can follow them. And if they don't have an agent to help sort that out to help interpret what they wanted. It makes it even that much more difficult. Advanced directives have limitations. We discussed in an emergency, they're going to do what they have to do. They're not going to be dealing with your advanced directives. There's also when you state, I want to be at this facility, and there may not be a place available for you in that facility. So if you make it very specific to that facility and that doctor, it makes it harder. Unless you have an agent who can say, okay, he's not there, so let's figure out how we're going to apply it to this, to where he is and who he's working with. But if there isn't somebody to help interpret, if you weren't able to find an agent, then a lot more is going to be up to interpretation. And if it doesn't give them that room, it's going to make it harder to follow along. There is a difficulty anticipating future circumstances, which is why people want to update these things. If it gets out of date and we didn't know there's new medicines, or I want to be part of a research study or whatever it is, again, it limits what they can do. And if it limits it too much, it may not be able to be followed. If your preferences conflict with general medical practice or relevant laws, they're going to say we can't follow this. And again, that's a discussion they can have with an agent that you specify, but it's not a discussion they can have with your document. But as David will talk to you soon, there are other things. There are other laws and other things New York has done to try to help when these issues come up or when we haven't had the chance to do our advanced directives. But it's always better if somebody can specify everything for themselves rather than leave it up to whim, chance, family, other things that David will talk about. Thank you. Next. So the things you want to talk about, your medications, what you want, what you don't want. Again, treatment facilities. Certainly, you might want to also talk about your disposition plan, because by the time they're working on it, you might not be quite ready to weigh in the way you'd like to when you can before a crisis begins. So you can put in your treatment. You can also put in, they can put in where they might want to look, or, you know, I definitely don't want to go there, or I'd like to go here. And it could include things about individual preferences, should include individual preference, things you do and don't want. And you know, again, we're not going to go line by line, but you want people to understand. The more that they let people understand what they want, the better chance this will be followed. If they're able to find an agent, that's why we talked about new ways to build those natural supports. Hopefully, you know, you can find people, pair them up, and we might have increased natural supports while they just agree at the beginning to be each other's healthcare agent. Thank you, Rob. So as we said, what constitutes end-of-life care? Not strictly psychiatric advance directive, but we never know what's going to happen. So if people have specific wishes about that, we want them to specify that, because sometimes we go from one crisis to another and we don't want people being treated in ways that they didn't want to, kept alive when they don't. Or, you know, Rob mentioned the medical orders of life-sustaining treatment. I don't want to be kept alive on tubes necessarily for years, but I'd like them to do CPR if I fall down in the hallway and they see my heart stop. I want CPR. I want to specify. It doesn't have to be DNR. It doesn't have to be one or the other. I would like to specify what I do want and what I don't want. Now an agent has a lot of latitude, but they won't be allowed to make decisions about artificial nutrition and hydration. If you're being kept alive by a feeding tube and hydration, they won't be able to say, I have no idea what Larry wants, but I say, turn it off. Or I say, don't turn, turn it off. If he needs to know, your healthcare agent needs to know what your wishes are. That's a discussion that it should be part of that preparation to say, you're going to be my agent. I don't want to be kept alive this way. I do want to be kept alive this way. There are a lot of decisions they can make based on their judgment of their interpretation of what you said, but that's not one of them if they really say, I don't know. So, I don't see the slide number. I think this is still me, right? Is this still me, Rob? Rob?
That's still you.
What slide is this, please? Because there's no number.
This is slide 25.
Thank you.
have this one and the next one.
Thank you very much. So again, this is all paperwork, physicians' names, outpatient mental health care providers, approaches that are helpful. Again, I said people take a lot of that from their RAP plan. That presumes that they made a RAP plan. Otherwise, they're going to figure these things out for here, and then they can transfer it when you discuss RAP plans with them. It's good for them to know, people know what are not helpful. Things that regard physical contact. Some people, when they're having a rough time, they want to hug. Now, we're not big on hugging at facilities, so maybe those weighted blankets will make a comeback in the hospital. So preferences regarding hospital community treatment programs, outpatient planning, as I mentioned, post-hospitalization, so that they can often, disposition planning may begin before you're ready to be a part of that. You don't want someone deciding, well, we'll send them here this time or her there. Additional preferences, anything you can think of that will be a part of your care, could be, shouldn't be. We want to have them out. There are forms for all of this, guideline forms. As Robert mentioned, there's a legal form for making an agent. Hospitals and the state have DNR and MOLST forms. But for the advanced directives, there are guideline forms. The state has a few, and you're going to hear from OMH about a system they've put in to really help you with getting these things going now. So next, please. And finally, signatures. Now you'll notice the signature of the person making the advanced directive, the statement, the witnesses sign, and their signatures and date. They have to declare that you would, making these decisions of sound mind, acted of your own free will. Nobody was making you do it. You'll notice again, I mentioned this earlier, the agent doesn't sign. I have seen forms where they do. It's not a legal requirement. It's a very good idea. It shows that the agent saw the forms. Again, we remind you of this a couple of times, because some people have said, my brother will be my agent, my friend will be my agent, my therapist will be my agent. That became news to that person when the person was hospitalized and their advance directive was brought to the agency. And by the way, you'll find out some good ways to make sure people know about people's advance directives. So now I know I'm done. Thank you very much. I'm going to turn it over now to my colleague, David, and take it away, David.
Cool.
David, you're muted.
Muted, David. You're muted, David.
Okay, there we go. So the thing is, if I don't know that I have a right, then I don't have a right. I have to know what I can and cannot do. So the provider responsibilities, the provider has to inform the consumer about the right to accept or refuse medical treatment and to create an advance directive. So the person has to know what they're allowed to do. The staff has to be educated and the community has to be educated about advance directives so the people in the facility know what's going on. Everything has to be documented. You can't document too much. So document in the record whether or not the individual has the directive, and then arrange for the directives or the copy to be inserted in the principal's medical record so that it's there. This will come up, should the person be hospitalized or go into a facility, then that is there for the staff to know about immediately. Now, it's not to condition the provision of care or discriminate against the person because she or he does not have an advance directive. We want to make sure if you do have one, you're going to get the care you want, but they cannot work against you if you don't. However, the more that's known about what your wishes are, the better. Next, Rob. To activate the advance directive, first thing is to notify the agent. The agent needs to know. When I am the healthcare proxy for a friend who's in a nursing home, we sat down and talked about what he wanted, how he wanted it. you have to comply with the healthcare decisions made by an agent in good faith to the same extent as if such decisions had been made by the principal. So that again, the nursing facility where my friend is, they know that I am the healthcare proxy, and they know that I have his best interests at heart. And then to document all actions, no matter what they are. Documentation should be the norm anyway. Next slide.
You know, David, I just want to kind of chime in here just for a second, because this notification requirement for the agent is super important. This actually happened to me, that I had conversations with someone about, you know, being a proxy, and we never really formalized anything. And then this person is at the end of their life, and the family is saying Rob's the person making those decisions, and it was never really formalized. It really put me in an awkward situation. So you have to make it clear.
Right, and just to go in on that, there's the difference between a surrogate and a proxy. The surrogate exists if you do not assign a proxy, and the order goes from guardian of the person to the spouse of the person to the oldest living child, then to the spouse, and then to a friend. So to let people know what I want, who I want to have doing this. In the case of my friend, his sibling, who is the only one living, is somewhere in West Virginia in a nursing facility himself. So, you know, Jess knows that I will be able to take care of him, and he's chosen that. So the individual has to understand the right to informed consent and to refuse psychiatric treatment and to create an advance directive. So the person has to know this, that they are allowed to do this, and that we have to give the individual has to know that they have that right. The individual has to choose an agent wisely. So to choose someone that you know is in line with your own values. It may be a person of your own faith, the person who is ready to do anything. Did you say surrogate defaults? No, after spouse, eldest child after spouse, before parent. Then obtain permission to appoint the agent, describing healthcare values and choices to the agent so that the agent knows exactly what you want at any given time. And then seek necessary information providers or others. Next. The individual, again, in creating the advance directive and the documentation, carefully describe the healthcare choices and preferences in the advance directive document. Again, there are a lot of forms out there that a person can use. There is a form which takes about 2 hours to fill out. It is exhaustive, but it is worth going through, and you can go through this with your agent so that your agent knows exactly what you want. You provide copies of the document to the agent. I have a copy of Jess's. To the treatment providers, that goes to the nursing facility, and to what family members are interested, and of course to his primary care physician. Keep the copy of the document in an accessible place. He has a copy, of course, right in his drawer, and I have a copy in his file in my apartment. And then review and update the document periodically. We've been talking about this about every 3 months, just to make sure that his wishes have not changed. His kidneys are failing, and he wanted me to be sure that he knew that he did not want dialysis, for example, or a catheter. So just to keep up with that type of thing as his situation develops. Next. Getting the ball rolling. Laminate the AD card and put it right near your insurance card in your wallet. This is if you're still walking around outside, but to make sure that people know you have an advance directive and to check it. As Larry was talking about, discuss this in rap groups when you get to the crisis plan part of it, so that you have more input on what's going on, and your suggestions to other people may help. For providers, tell people about it at intake. Especially target people who are just coming out of the hospital so that people know what's going on with advance directives. have the forms and information on advanced directives available in the waiting room area, so people have access to it and so that it's in their mind. Have signs in the waiting room, ask us about advanced directives. And providers are often now asking about this. I've been asked about it and to make sure that I have an advanced directive in place. And then connect and collaborate between inpatient and managed care organizations so that your insurance company knows what's going on as well as the hospital. Next. This is a copy of the ID card. So you can see the person carrying this card, David Ferentz, has mental health and physical advanced directive on file. Please see the reverse side before providing any treatment. And then it tells where that is, who the care agent is, and the phone number of the person. So they know if the person is non-responsive, they know who to call immediately so that the person can get what they need as they're moving through. Next. So this form that is referenced here it's an amazing form. Again, this one takes about 75 minutes to 2 hours to go through. It is exhaustive and will provide a number of things. One section, for example, has a list of things that a person would be willing to take, and it's numbered 1 through, I think, 7. The person chooses them. So restraints, why or why not, seclusion, why or why not, restraints and seclusion, why or why not. The AD card, you will be able to print that up when you get the PDF. And I'm pretty sure you can find this also on the OMH site. So, yes? Okay, so it lists all these things and you can say which one you want in which order and then your reasons for that. And this goes all the way through all these different areas. So it is worth going through and worth going through with your agent. Next. If I don't have a healthcare agent or advanced directives, am I out of luck? No, you aren't. The New York Family Healthcare Decision Act establishes the authority of a patient's family members or close friend to make healthcare decisions for the patient in cases where the patient lacks decisional capability and did not leave prior instructions or appoint a healthcare agent. This is what happened with Rob. The surrogate decision maker would then be empowered to direct the withdrawal or withholding of life-sustaining treatment when standards set forth in the statute are satisfied. But it does put, as happened with Rob, this can put somebody in a very tricky position. You know, what do they want? And those surrogates can say, I don't want to do this, and it keeps going down the line. And in this case, it ended up with Rob as a close friend. But it is good to have an agent, to have someone who knows what's going on, and to allow that person in on what your desires are. This makes it easier for the family. It makes it easier on your friends. It makes it easier on your family of choice. It makes it easier on your doctor, everybody, to have somebody empowered to do this for you. So for those under appointed the Family Care and Decision Act, the law protects both the surrogate and the proxy. So I am not held responsible for the costs of care if I follow what Jess wants, and the surrogate would not be responsible for such things either. And if the person, if the person were to die because of choices that I made as the proxy, I am not held liable for them if those decisions were made in good faith. So those things, that good faith can be determined by a couple of physicians, but the thing is that the person is not held liable either for costs or for any kind of criminal activity or anything else if they're making those decisions in good faith. Next. So can you have a PAD without a proxy? Yes, you don't have to have a proxy, but it can limit the flexibility and usefulness. So as Larry was saying, it might be that I put down a specific hospital that I want to go to, but there's no rooms there. Well, the proxy might know, well, yes, these would have been his second choice because he knows a therapist who's there, a psychiatrist there that he feels comfortable with. So the proxy can make choices on your behalf that you would have been happy with in the end. Can my healthcare proxy be a signing witness? No, they cannot sign as a witness because they cannot sign saying that they are now the proxy. You have to get another person to do the witnessing. Next. Does anyone have to approve my advanced directives at the time I make them? No. However, if you are creating healthcare proxy, you must follow statutory formalities. You have to write your wishes in a document, and it has to be signed by you and 2 witnesses. Witnesses must be people other than your agent. If you reside in a mental hygiene facility, one of your witnesses must be unaffiliated with that institution, and 1 or more must be qualified mental health professionals. If you're creating a living will, you are strongly advised to follow the same procedure, although it is not a legal requirement at present. This applies also, your agent can also be your power of attorney, but both of those have to be put into separate documents. Does the statute say anything about when my mental health providers may decline to follow my advance directive? Yes, to a limited degree. If what you are wishing goes against the religious belief or moral convictions of the attending, then that person can refuse to follow the advance directive. But they have to find somebody who is willing to do so. So the attending physician has to find someone who is willing to carry out your wishes. The court also has the power to override the agent's decision if it's shown that the decision was made in bad faith. So you have to be careful about who you're choosing, especially in situations like this, or if the agent was not exercising required type of judgment. If you are considered a danger to yourself or to otherwise in an emergency, it is likely that the healthcare providers could decline to follow your healthcare proxy or living will. If you attempt suicide, you will be revived. You will be taken care of, and they will do everything they can to save your life. So, if that were to happen, then your advance directive will not be followed. Next. So for Kendra's law, if a person has a healthcare agent, then the agent must be notified that a petition has been brought. So if a person falls under Kendra's law, that is that they fall within that narrow group of people that the law applies to, so that they are a danger to themselves or to society, then if that person is been brought into the legal system in that way, the agent has to be notified immediately. Any directions included in the patient's healthcare proxy shall be taken into account by the court in determining a treatment plan. So again, the healthcare proxy is able to speak on behalf of a person as to his or her wishes. Then the legislature finds that voluntary use of such proxy should be encouraged so as to minimize the need for involuntary mental health treatment. So the healthcare proxy can make decisions for the person if the person is deemed incapable of dealing with that himself or herself. It allows for people with serious mental health issues to make sure that they're going to be treated in a way that they feel comfortable with, they're going to be happy with in the end. Next slide. There's these 2 slides that are here show a lot of the case law concerning advance directives. And the court, for example, well, I'm not going to go through all these because they are worth looking up for yourself, and you can read these. There's an awful lot here. In the next slide also, the legal basis, New York health law, New York SCPA law, New York public health law. The New York state does not have a statute governing living wills. So there are examples for a living will that you can find, but there is no statute concerning living wills at this time. And then public health law also for advance directives. Next. So for today's takeaways, it's important to encourage everyone to think about these issues. So both for people who would be considered agents, for people who have mental health issues, for people who have physical issues, actually for any person, to let people know what's going on. If I am in a car accident and I am incapable of making decisions, it's good to know that my best interests are being taken care of, whether that be DNR, whether that be limited life support, whether that be certain types of treatment. It is worth it for me to have that so that it's not the burden on other people. That's an important thing for us to be aware of. Putting together these documents, having an agent is a gift to the people around me. Helping people with process. Eldest child is after spouse. Yes. Helping individuals with the process. So in whether with RAP plans or wherever else, so that people have the things that they need in order to take advantage of these processes. Utilizing advanced directives and instructions is the best opportunity to have your wishes met, so that these things are on file. We have copies of them. Our agents have copies of them. If we go into a facility, they're in our record. All of these things are in place to make sure that we're getting what we need and what we want in the way that we want. And the Office of Mental Health is a partner in helping you facilitate this process. And we have someone, Kirsten, who is going to speak now about what the Office of Mental Health has to offer. So Kirsten McLaughlin, take it away.
Hi, good afternoon. And I just wanted to take a moment to thank the organizers of today's training for inviting me to come speak with you all today. And I'm really looking forward to discussing the Psychiatric Advanced Directives features within the Psyche's application, which has been available since February of this year. And my name is Kristen McLaughlin. I'm part of the Psyche's team at the OMH at the Office of Mental Health. Next slide. Great. So what is Psyche? So I'm not sure if everybody on the line today is familiar, but just a brief overview. The Psyche's application is an online web-based application that can be accessed on any internet browser, and it's secure and it's HIPAA compliant. And the purpose of the Psyche's application is for sharing Medicaid claims and encounter data, as well as other state administrative data. So what Psyche's does with all of this data is that it puts it into a user-friendly format, and it's designed to support clinical decision-making on an individual level, as well as quality improvement on more of a provider population trend level, because you can use the data that's collected within the application to either make plans or focus on, specific problem areas. So those who do know Psyche's probably know a couple of the features that it has. So one of those are the quality indicator reports. So quality indicators or quality flags identify clients who meet criteria for certain quality concerns or treatment issues, such as, maybe prescribing practices or service utilization. And the MyQI report could show an agency's or a network's current performance on those quality indicators. And then we also have population health management reports. So those things are like recipient search, where you can run ad hoc reports to identify cohorts of interest. So, maybe particular folks who have high need or high risk, or Health Home Plus eligible, or receiving certain services. And then you'd be able to see a results page that would provide a count and the list of the clients who are meeting that said criteria.
Kristen, did we lose you?
It's sounding like we might have, Rob.
Oh boy.
So let's, you know what? We'll give her a minute to sign out and sign in. She hasn't signed out yet, so maybe she'll be right on. But if her connection got lost, maybe she'll. Yes, I think she'll sign. She'll probably come back. So,
Sorry about that. Can you guys hear me now?
Even better, yes.
Yep.
Okay, sorry about that little technical glitch. Could someone let me know where I left off before I got disconnected?
You were just starting the fourth bullet.
Okay, perfect. Thank you so much. Sorry for that. So what we were talking about was like part of the clinical summary. So we were mentioning that how it's summarizing up to 5 years worth of treatment history on a client, and it creates that integrated view from all the different data sources that Psyches has available to the application. So that's Medicaid billing, state psychiatric center information, health home information, suicide risk from the incident management system for the state, AOT court orders. So it is able to take all this information and organize it into sections. And that's what we're looking at, this fourth bullet here. One of the sections in the clinical summary is the plans and documents section. And within this section, you have a couple different options. The first is the upload, which allows you to upload a completed psychiatric advance directive and attach it to the client's clinical summary. And then we have the create link that's also in that section, which then will link you to the NIAPRIS pad, so the NIAPRIS Psychiatric Advance Directive template, which is a fillable PDF. And that was added, as I mentioned, back in February. So next slide. Great. So let's talk about the Psychiatric Advance Directive and Psyche. So when
Hi, my name is Maura Kelly. 8/22/1963. I'm trying to reach Amanda Brooks for a.
Thank you. So when a pad is uploaded and attached to a client's the Psyche's clinical summary, it can be accessed by other providers working with the client. And we were talking about that earlier in the presentation, how accessibility and the actual getting information, getting the pad information is important. So an example of this is if a pad is uploaded and attached to a client's clinical summary, let's say staff from the emergency room or from a mobile crisis team is using Psyches, they can then access this client's pad, either with a client consent or if it's deemed a clinical emergency, and that will give them access to the person's clinical summary for 72 hours. So I will let folks know, I think this might have been mentioned earlier in the training, is that a separate training is going to be held next month on July 28th at 1 in discussion of how to actually go through the process of uploading a psychiatric advance directive in Psyches. But if you don't want to wait a month until getting those steps, I would want to let folks know that we do have a step-by-step instruction guide that's available on our website. And it's under on our website, psyches.com or psyches.org. And it's under the section Psyches training materials. And that will show you a step-by-step guide of how to upload a pad in Psyches. And if you have any questions about data or functionality in regards to this feature, you could always contact our Psyches help desk, which is psyches-help@omh.ny.gov. And we are available Monday through Fridays from 9 to 5 via email. And we give our users within 1 business day a response. Thank you.
Thank you, Kristen. I really appreciate that. Here are some of the resources that we used for today's training. If you want to go deeper in your learning, you will receive a PowerPoint, and you can go deeper in your learning in any of these resources here. Lots of literature references. As Kristen mentioned, there is another training coming up. We're pleased to announce this on we have a second webinar on July 28th from 1 until 2:30. Zoom invites will follow. So we're going to just continue on this important topic, probably over the next several months at that.
And I'd like to, thanks to OMH, that's something that's been mentioned throughout today was an advanced directive doesn't work if people don't know about it. So this adding it to Psyche is so important. Having the AD card, somebody asked about the AD card. It is in that template that OMH that Kristen told you about, but you should know, you could also just write a little card. And the key is you want to stick that, people should keep that with their insurance card, because if you've ever been at the hospital, you know 2 things. They will find your insurance card, Medicaid, Medicare, private insurance, and they will stop looking once they find your insurance card. So in order to make sure they have your AD card, keep it with your insurance card. And, because again, we want people to adopt this. OMH is doing a big step to help more and more advanced directives get done, but people also have to know about them and at the right time. When people are in the hospital, the agent needs to know they're the agent, and then they find out you're in the hospital, they can also bring that document there. So we just want to reinforce that before we, go to questions and stuff.
Thank you, Larry. That's actually some really good advice there, because you know that they're going to find your insurance card. So if you have your AD card nearby, they're going to find that too. So that's some great advice. So as we have about 15 minutes left, and just want to see if there's any questions in the chat box. We'll be happy to answer them as best we can. Lots of times people get very specific into their questions, and if I always recommend, if you have specific questions on any of this, it's always best to consult an attorney. But Larry, do you have any questions in the chat box?
Somebody asked if we will be sending the recording. So we don't send it. It's a big file, but sometimes they post it on the website. I don't know if they plan on posting this, but I imagine they probably will. So you can check the NIAPRA site under their 2021 section of webinars, and at some point soon, usually it'll be posted with the PowerPoint, but they will be sending out the PowerPoint with the CEU information, I believe.
Okay.
So someone asked please mention about the resources again.
I'm not sure which resources they were referring to.
Yeah, I'm not sure either.
A suggestion would be to note that you will have access to the PowerPoint. So you'll be able to download that and take a look at the slides themselves. There's an awful lot there. There's a lot on case law. There are a lot of links to forms and the like that will be there. And I downloaded and looked at a number of these things and had dinner with a couple of lawyers that I knew, and we went through a bunch of them. And we just used the PowerPoint to find out everything that we needed, that they needed to explain to me. So.
And they may be referring to the National Resource Center on Psychiatric Advanced Directives or the Basildon Center. So either one are really good resources for people to utilize, keeping in mind that they're national, although the National Resource Center on Psychiatric Advanced Directives, you can go state by state. And,
right, they have state links, so
they have state, so that's helpful for people as well.
The other thing that you might want to do, there is no official no official psychiatric, but you can have that as part of your advanced directive.
Right, there's an official healthcare proxy form, and there's an official, although hospital versions of the DNRs, but for the psychiatric advanced directives, there are models out there to make sure you include everything you would want to include. And one of, as OMH mentioned, one of them is available on the Psyches, and if you type in New York State advanced directives, you'll get a link. You'll be able to get directly to the forms New York State offers. They're not recommending anything, but they're offering forms that take into account everything they want you to talk about.
Here's another question. Do OMH providers insurance advise patients to seek advice of counsel? I would assume that that's an individual or organizational. I'm not sure OMH has and maybe Kristen, if you could chime in on this one, if OMH does this or not, but I'm sure organizations might be best practice, but I can't speak for all organizations and insurance and providers across the state.
Yes, it's definitely considered one of the best practices. And we also know for AOT providers, it's one of the things that they need to be completing with any people who are on an AOT order. So it's definitely something that's considered best practice.
Great, thank you.
Yeah, one other thing that a person might consider if you are traveling, particularly if you're traveling anywhere out of state or somewhere in state for a vacation, include a copy of your advance directive in your luggage. Have that with you so that if you end up going into the emergency room or something like that, you will have that form with you to be able to hand over. And they will then know who to contact, your proxy or to at least know your wishes. So it is worth having this with you as you travel.
Great information, David, because if they don't know, they don't follow, right?
Right. And if I don't know that I have a right, I don't have it. And if people don't know my wishes, they will do as they please. And that may not be what I want.
Any other questions in the chat box, Larry?
I don't believe so. Let me just do a quick, no, I think we covered them. If anyone else has any last minute questions, anything anyone wants to ask or say, any of us, for further trainings, Rob has our contact up there. NIAPRA's collective offers free training on, I don't know how many we have now, 40, 50 trainings. They're all free to OMH funded and licensed organizations. Other organizations pay us a very reasonable fee, but for all OMH licensed and funded organizations, NIAPRA is able to provide free training funded by our contract with the Office of Mental Health.
And not just in the area of advanced directives. I mean, we train on recovery, on person-centered practices, on employment services. The list is pretty extensive. So if anybody would like a brochure, we would gladly, get that out to you for future training, free training opportunities at that.
Yes, you can contact any of us. We as Rob said, managing a crisis, wellness recovery action plans, so many things out there, trauma-informed care, cultural competency. A lot of places have annual requirements around those. We provide all of that free to OMH licensed and funded organizations.
And given the pandemic and everything that's been going on, I've been doing a number of things on burnout. So our burnout, dealing with burnout has been a popular and useful tool for a number of people. So.
And you should know all our training we can do online. We have created online versions for the handful that were more challenging. We have an online of every version, but as things open up, you'll have a choice. But we have been approved by our funder to continue to work as a hybrid organization. For some agencies, online has been working best. They can continue to do that. For other people, if they want us back in person, as long as the guidelines are out there or the emergency is being lifted, then we can do that too. Thank you, guys.
One final comment on CEUs. People who would like CEUs, we're actually going to be sending out a link that you will sign in and sign out link. The sign out link actually takes you to a evaluation form that you would need to complete. So once those forms are completed, it does take about 4 to 6 weeks for us to get you those certs back to you. We're doing a lot of these all across the state, so there's lots of them that we have to go through. So you will receive those, as well as a copy of the PowerPoint.
Hey, Rob.
Yeah.
Somebody's asking about getting on the mailing list so that they can get about future training. And who would that be? Do you know who would I send them to? The office, I guess, to Eileen, or have them contact us and we'll forward it.
Yeah. Just contact one of us.
Depending on whoever's trainer is in your region, on the slide Rob has up now, you can just email one of us. So if you're in New York City or Long Island, you can email me that you want to get on the mailing list, and I'll forward that to the office. And our emails these are the easiest emails that I have ever had. Larry H at niapris.org and Robert S at niapris.org and David F at niapris.org. So which one of you guys is Orange County? I'm New York City and Long Island. So
that would be David.
I am Orange County, very much. Oh, and the idea of competency versus capacity. A capacity is determined by 2 physicians. Competency does go to the courts and is determined by the court.
Well, we really want to thank everybody today for taking part in this important topic. We hope that you join us July 28th at 1 o'clock for really more of an in-depth of the psyches part of things here, and Kristen will be a part of that as well. But again, we want to thank everybody and just have a great day. I know it's hot everywhere in New York State. Find a place to be cool and enjoy the rest of your day, everyone. Bye-bye.
Bye.